Live.
Acha live.
So, good morning, respected faculty and dear delegates. On behalf of IIP Delhi, I welcome all of you to this third session of Mastery classes in Pediatric Nephrology. Today, we'll have a session on vitamin D deficiency and rickets. We are joined by Dr. Indira Agarwal, who will be taking this session, and our expert, Dr. Khana Sharif. And we also have Dr. Pankaj Garg, past president of IIP Delhi, and Dr. Praveen Kumar, who will be chairing this session. He's the head of the department of Kalavati Saran and head of the Department of Pediatrics at Kalavati Saran Children's Hospital and Medical College. And I request Dr. Neha Bhandari ma'am to please, and we also welcome Dr. A.S. Vasudev sir, who was the past chairperson of the nephrology chapter. And I request Dr. Neha to please introduce the experts and the speakers and chairperson. Before that, I request Dr. Pankaj Garg sir to say a few words.
Morning, everybody. This is a very exciting session. Though I was thinking that vitamin D deficiency comes in domain of nutrition, but yes, there's a lot of things which are beyond nutrition, and then nephrologists come into action. This nephrology whole seminar has been very interesting. I've been attending the first session on investigations and proteinuria. I must compliment Dr. Neha for making it useful to all of us, including neonatologists and pediatricians and everybody. So thank you, Dr. Vasudev and Dr. Neha, for excellent work in pediatric nephrology and IIP Delhi, who has been really pioneering this academic program in the country. Thank you so much, and back to Dr. Ajay.
Thank you, Dr. Pankaj. Dr. Neha, please introduce these experts and the speakers.
Thank you, sir. First of all, welcome all to this eNephrology module, and this is the third session that we are having, and we had a wonderful response from everyone, especially all our delegate group, because they were very happy with the previous classes, and I'm sure this class will also be a very enriching experience for everybody. And we have pioneers in pediatric nephrology with us. So first of all, I would like to welcome Dr. Ruxana Shroff. So madam is a professor of pediatric nephrology at Great Ormond Street Hospital for Children, University of Chicago, London, UK. Her research focuses on bone and cardiovascular diseases in childhood CKD, aiming to improve outcomes in children on dialysis. And she has led several international multi-centric trials. She's the president of International Pediatric Nephrology Association currently, and she's also the co-editor of 8th and 9th edition of Pediatric Nephrology book, which all of us do read. And she has been the chair to many scientific chair to European Society of Pediatric Nephrology meeting in 23 and IPNA in 25. She has received a senior fellowship from National Institute of Health Research and served as a member of KDIGO Executive Committee. She has led a lot of research guidelines as the committee member as well as the chair. She is also a chair of ESPN Dialysis Work Group and represents pediatric dialysis at European Renal Association. She has been working a lot in pediatric renal nutrition task force, and she chairs the ISN Sister Renal Center program. And she has also serves editorial board of several journals and published over 400 peer review journals. So it is, I would like to welcome on behalf of IIP Delhi and everyone, ma'am. Thank you so much.
Welcome, ma'am. Welcome, ma'am.
Thank you. Thank you, everyone. Nice to be here.
So next, I would like to introduce our speaker. So madam is somebody who is, I think, pioneer of pediatric nephrology in India. She is known everywhere. Wonderful person and one of the best pediatric nephrologists I have met. She's professor and head pediatric nephrology department, CMC, Vellore. She has published over 100 national and international journals. She has been ISPN Fellowship Committee Chair, as well as she has also been a member outreach committee program of IPTA from 2024. She has also been a member of IOSIN Fellowship Committee, ISN South Africa Regional Board from 25 to 27. She has been the past president of Indian Society of Pediatric Nephrology from 2012 to 2014. She's currently also the coordinator for ISN Fellowship 2001 Women's and Children Hospital, Adelaide, and also 2-year fellowship pediatric nephrology program that is run under MGR University since 2012. She's also the course coordinator for that. So welcome, ma'am, and looking forward to have a great session from you.
Thank you for that kind introduction, Neha. And thank you to IUP Delhi for giving me this opportunity to be speaking today. So I'll just share my slides.
Welcome, ma'am. Before we start, I request Dr. Praveen Kumar, Professor of Pediatrics and Head of the Department, to say a few words.
Yeah,
Dr.
good
Praveen?
morning, everyone, and thank you, Dr. Ajay, and thank you, everyone. So I think this vitamin D deficiency, we all know this is a major public health problem, and Indian Academy of Pediatrics published its consensus guideline few years back, but then there were several research gaps, and definitely this session is going to help us understanding better and more clarity we will have. So without taking much time, I think we will hand over to speaker. Thank you, Dr. Ajay. Thank you.
Thank you, Dr. Praveen. I request Dr. Indra ma'am to please start this.
Yes. So thank you, everybody. And today we will be covering this topic of vitamin D deficiency and rickets, and how common is vitamin D deficiency, and when is it not vitamin D deficiency, and it is, the other causes of rickets, what we call refractory rickets or refractory vitamin D rickets. So we shall start with understanding the pathophysiology. What is the classification? We need to understand the calcium phosphate vitamin D metabolism for us to really know how, what type of rickets it is. We'll go through some case scenarios. We look at the regulators that are involved, especially FGF23. How do we approach the evaluation? And then finally, there will be an algorithm on approach to rickets. So rickets is a disease of growing bones, as we all know, and it results from alterations that occur in the calcium and vitamin D metabolism. The symptoms might depend on the patient's age, the duration, what the underlying disease is, and not just the clinical features, which often don't really help us to differentiate between the different types of rickets. Now, nutritional rickets due to vitamin D deficiency and dietary calcium deficiency is the most common form. But now we know that there are many other more causes of hereditary causes of rickets, which we tend to see in our day-to-day lives. Now, how do we recognize rickets? It's important to know that there's a very important role of phosphate, more than actually calcium, that is involved. And it results because of the impaired apoptosis of the hypertrophic chondrocytes that are present in the growing ends of the bones. And this results in widening of the growth plate. And we shall come to that shortly. And as a result of this, there's impaired mineralization of the growth plate. And this can be radiologically demonstrated, as we are all familiar with this metaphyseal fraying and widening of the growth plate. And in conjunction with this is the elevation of the osteoblastic marker, which is the alkaline phosphatase. And therefore, broadly, rickets may be classified as calcipenic rickets or phosphopenic rickets. So let us look at it. So we know rickets can be nutritional or hereditary in origin. 85% is nutritional, and it may be from insufficient vitamin D intake or insufficient calcium intake. It may also be due to insufficient phosphate intake or lack of absorption. Whereas when the hereditary rickets, which is only 10 to 15%, may be due to vitamin D metabolism problems or some problems in the phosphorus metabolism. So this results in either calcipenic rickets or phosphopenic rickets. Now, vitamin D deficiency is quite prevalent, and especially not only in very young children, where it may be about 14%, but also in school-going children, where it may be up to 18%, and adolescents, it may be up to 24%. Now, if you just broadly look at the metabolism, what really happens? So if you have decreased vitamin 25-hydroxy vitamin D or a decreased intake of calcium, so you end up with a low absorption of calcium, low calcium, serum calcium. This results in stimulation of PTH, and this has three major actions. One is the renal phosphate wasting. It also tries to stimulate 1-alpha hydroxylation of 25D to produce more vitamin D, and it also results in calcium mobilization from the bone. This is an attempt to increase calcium absorption, but sometimes you're not able to match up to that, so you may still have a low 25-hydroxy vitamin D. Then it goes into a decompensated state, hypocalcemic symptoms, and rickets. We'll come to this in a little more detail shortly. So then you have classified rickets as two types. One is calcipenic rickets and the other is phosphopenic rickets. Calcipenic rickets are generally related to vitamin D deficiency or resistance. So you might have dietary deficiency or malabsorption or lack of exposure to sunlight. Or there is a defective 25-hydroxylation vitamin D, which actually occurs in the liver. Or there may be a failure of the next step when there is 1-alpha hydroxylation of vitamin D to produce the actual vitamin 125-hydroxy vitamin D, and deficiency of this can lead to resist. or rickets, or there is an end organ resistance to the action of vitamin D, which is the type 2, or there is calcium deficiency or secondary to CKD. Whereas phosphatemic rickets are really usually associated with renal tubular phosphate loss, where this may be due to a genetic cause, where there's X-linked or recessive or dominant type of hypophosphatemic rickets, or another one which we call hypophosphatemic rickets with hypercalciuria, Fanconi syndrome, or a deficiency or a malabsorption of phosphate. So with this background, let's just look at what is this important role of phosphate. Now, this is the end of the growing end of the bone. You have the epiphysis, you have the metaphysis, and in between is this growth plate where there are chondrocytes, which are initially in a resting zone, then they go to the proliferating phase, and then they go into the hypertrophic phase. This is the final phase where differentiation and mineralization occurs. And for this, you need this apoptosis of these hypertrophic chondrocytes. If there is a problem in that phase, which occurs due to deficiency of phosphate, there is decreased mineralization. So this is better depicts this. So the growth phase or the proliferation phase where the chondrocytes are becoming hypertrophic, and for the calcification, there has to be necrosis for mineralization to occur, and these chondrocytes get arranged in a columnar fashion. However, if there is deficiency of phosphate, this is affected, decreased apoptosis, impaired mineralization, and widening of the growth plate. Now we'll come to a few cases. I'll just mention them. So we have a 1.5-year-old child brought by his anxious parents saying that they've noticed bowing of his limbs. All his milestones are normal. He's well grown. He has no urinary symptoms. His weight and height is normal. But he has this bowing. Calcium is normal, 9.6. Phosphate is 5, which is accepted for that age. Alkaline phosphatase, vitamin D, PTH are all normal. Creatinine is also normal. Now, the second child is a 2-year-old child with history of poor growth. But this child has history of recurrent respiratory infections, frequent diarrhea, and is being fed by a diluted milk formula. So child is dull looking, has streaky hair, pale dry skin, frontal bossing, AF is widely open, and all the features of rickets like rickety rosary, widened wrist, genu-valgum is also present. And his HB is low, 7.3. Calcium is on the lower side, 7.5. Phosphate is low. Alkaline phosphate is slightly high. Vitamin D is low. PTH is slightly high, and creatinine is normal. Now, the third child is a 5-year-old child with history of bowing of legs. He's a known case of PU valves, which were fulgurated. After that, he did not follow up. And then later, they noticed that he was not growing well, lagging behind. But they still didn't really do anything about it till he had a UTI. And when brought to the doctor, he was noted to be stunted. There was pallor, frontal bossing, widened wrist. He had poor growth. His BP was slightly high. He had genu-valgum. And investigations showed a low HB again. His potassium was slightly high at 5.6. The bicarb was low at 16. The phosphate was high at 5.8. Again, alkaline phosphatase was elevated. The vitamin D was low, and the PTH was very markedly elevated. And as you can see, his creatinine and urea were also elevated. Then you have another child, a 3-year-old with bowing of legs. Now, this one was also seen by a local practitioner, given vitamin D, but there was no improvement. This child was noted to have, in addition, some dental caries. Weight and height was sort of okay, but this child had a disproportionate short stature and poor dentition, and along with that, slightly hypotonic. Now, this child's investigations, sodium, potassium, bicarb were okay, creatinine was okay, even calcium was all right, but phosphate was extremely low. Alkaline phosphatase was high. The vitamin D was actually normal and the PTH was normal. So what is this child having? We'll come back to them later after we discuss the metabolism. Then I have a 2-year-old child having bowing of legs, developmentally normal, and also again treated with vitamin D, but there was no improvement. This child additionally was noted to have alopecia, and when examining the child, they actually noted that this child had tetany as well, along with all features of rickets. Now, the investigations here, the renal function was okay, calcium on the lower side, phosphate on the lower side. Again, alkaline phosphatase elevated, but here vitamin D is normal and PTH is slightly elevated. Now, what do we do here? Do we need to look at 125 dihydroxy vitamin D, a test which is not very freely available in the labs. So, but in some situations, you may need to consider it. And then the last one, a 3-year-old child was brought with failure to thrive, poor weight gain, delayed milestones again, walked only at 2.5 years. But here there was a slightly different history of increased thirst and frequent voiding, and child was still bedwetting at night. So he also looked dull, wasted, with poor skin turgor, normal BP otherwise, all signs of rickets. But the child had a liver palpable 4 centimeters below the costal margin. And here we can see that there was also acidosis and the chloride was elevated with an anion gap of 12 with normal urea and creatinine. pH urine here was tested, it was 5. Again, phosphate was low, for calcium was low, alkaline phosphatase high, and vitamin D and PTH, vitamin D low and PTH slightly high, and there was hepatomegaly. So what is this child having? So we'll come back to this once we understand the whole pathophysiology of vitamin D. So to start with, you have low vitamin D, the D2 or the D3. D2 comes from the dietary deficiency when their food is lacking in calcium or vitamin D. Whereas it can also occur paradoxically in our own country, though we have enough sunlight, because we tend to we have dark skin and there's decreased melanin that's present in the skin, which actually decreases the absorption of vitamin D. Or we tend to wear a lot of covered clothing, or we stay indoors because of the heat, or we use a lot of sunscreen. So because of this, you may have a low absorption, and so low 25 hydroxy vitamin D. So because of this, your 125 hydroxy is low. Because of this, there's decreased intestinal absorption from the gut. This results in a low calcium, which is set below the point. So this, what do we do to increase this calcium? So this is sensed by the calcium sensor cells in the PTH, and that is why the PTH goes up in vitamin D deficiency. So you get a secondary hyperparathyroidism. So what does this PTH do? This tries to increase the vitamin D production by increasing 1-alpha hydroxylase, and this tries to increase the calcium from absorption from the gut. It also stimulates the osteoclasts to release calcium. It also tries to increase the calcium absorption from the kidney, but at the same time, it also will result in increased phosphate excretion. So because of this, there may be a reduction of, in the process of time, low serum phosphate. And if there is a failure of the compensatory mechanism, the serum calcium will also be low. So how does this manifest? So when you have hypophosphatemic complications, there will be rickets, there will be rachitic rosary, there will be growth plate widening, as we already spoke of, and there will be osteomalacia. Whereas if you have low serum calcium, the neuromuscular system gets stimulated, so there will be irritability and seizures. With prolonged hypocalcemia, you can even have a dilated cardiomyopathy, and there may be tetany. So this is just a summary slide where it shows that if you have deficiency of 7-dehydro cholecalciferol, so there's decreased formation of D3 or D2. So this results in nutritional rickets due to decrease. There are increased requirements in infancy and adolescence, and that may be due to decreased or exposure to sunlight and the host factors and environmental factors. So this results in nutritional rickets. Now, if the next phase is affected, the conversion to 25 hydroxy vitamin D or the 125 hydroxy vitamin D, this may be due to, this is what we call non-nutritional rickets. It could be from liver disorders, renal disorders, or even GI disorders when there is malabsorption, because these are the actions of 125 hydroxy vitamin D. It's either on the intestine or on the bone or on the kidney. So this is a simple table which actually shows you the stages of rickets. In the initial stages, only the alkaline phosphatase may be high. The PTH is trying to compensate. So the calcium may be normal, even the phosphate may be normal, but 25 hydroxy will be low, and it is trying to regulate the 125 levels by trying to increase it. However, it becomes clinically apparent probably in stage 2, where the phosphate levels actually go down and the PTH goes up quite remarkably, and both 25 and 125 will go down. Stage 3 rickets is the most severe time when all the levels are affected, including the 125, and calcium really becomes very low by then. So we hope to pick it up by stage 2 at least, if not by stage 1. So this is just a table showing what are the normal values and ranges for calcium and phosphorus. We need to remember that for younger children, we have higher ranges compared to older children at 6 to 12 years, and for both calcium and phosphorus. So for us to know what is normal, what is low, and what is high, it is important to remember these ranges. And these are pictures which show you all the typical features of hypocalcemic rickets or calcipenic rickets. So you have bowing of legs, you have cupping, fraying, widening of the epiphysis, visible as these widened wrists. You might have widened anterior frontinel. You can see rackety rosary. You can also see valgum. This is a child which has alopecia and loss of eyelashes, which you see in the dependent rickets. And here you can even see pathological fractures, which can occur in children with rickets. Now, this is also another thing, comparing a normal and what is abnormal, showing you all the genu recurvatum that can occur. Here at the lower ends of bones also you may see cupping and fraying. And here you can see even in the metacarpals, there is some cupping that is noticed. Now, what is the homeostasis? How is it maintained? There is a complex interaction between the intestine, the bone, and the kidney. And this involves various calciotropic and phosphatic regulating hormones. And as you can see here, PTH can stimulate 125, 125 inhibits PTH. So they all interact with each other, and one will stimulate it, the other will inhibit it, and we'll come to this. So there is an improved understanding of the pathophysiology with the discovery of the very important phosphaturic hormone called the fibroblast growth factor, or FGF23. There's also been the easy availability of genetic testing, and this has revolutionized the diagnosis and management of rickets. It has helped in the understanding of the pathophysiology of many hereditary disorders. And because of this, we even now have targeted therapy available for some hereditary forms like the X-linked hypophosphatemic rickets, which can be actually treated now with burosumab. So this slide shows just the various receptors that are there. So you see with the PTH, you have the calcium sensing receptors. With 125 hydroxy vitamin D, you have the PTH1 receptor and the Rankel receptors, which facilitate its action. In the gut, you have TRPV6, which helps in the absorption of calcium, and the NAPI2 helps in the absorption of phosphate. And you have the FGF23, which is a very important regulatory hormone, which is a phosphaturic hormone, which works through the PTH1 receptor, and it inhibits the NAPI2, which actually inhibits the absorption of phosphate, resulting in phosphate loss when there is some abnormality in the action of vitamin D. Of FGF23. And you have the TRPV5, which facilitates the absorption of calcium. So there is a newer calcification for rickets. So you have the nutritional rickets, which we know, which is due to vitamin D or calcium deficiency or a combined deficiency or phosphate deficiency. Hereditary rickets now can be either hypophosphatemic, where it is FGF23 dependent, like the X-linked or the autosomal dominant or the recessive types of hypophosphatemic rickets, or it is FGF23 independent, where you have especially the hypophosphatemic rickets with hypercalciuria, which is the commonly known one, or it is vitamin D dependent, which is the type 1A, 1B, and so on. Then you have the non-hereditary rickets, which may be again FGF23 independent or dependent. Dependent is the tumor-induced osteomalacia or the iron infusion-induced. And dependent may be Fanconi's syndrome or due to toxins. There are other forms due to failures like liver failure, renal failure, or malabsorption, or some direct effect on the growth plate, which may be due to some toxic effects of some drugs or treatment. Now let us understand how vitamin D dependent rickets occurs. So we already spoke about sunlight and the formation of vitamin D3, and it becomes a calcerol. This needs to get 25 hydroxylated to form a 25 hydroxy vitamin D, and this is regulated by CYP2R1, the gene. Then 25 hydroxy is converted to 125 hydroxy vitamin D, and this is by the enzyme 1-alpha hydroxylase, but this is dependent on the cytochrome 27B1. So deficiency of this causes vitamin D type 1A, whereas this the 25 hydroxylation, when it is affected, it forms type 1B. Then vitamin D, the active form, requires the vitamin D receptors in order to exhibit its action. And if there's a mutation here, then it can results in the type 2A or a type 2B, which is actually a very severe form of rickets. There is a third type where it gets converted into some inactive forms by, again, cytochrome enzymes like the 24-25 hydroxy or the 124-25 hydroxy. And these forms are inactive and will also in their own way cause rickets, but they are very rare. Now, this is a little busy slide, but just to show that the vitamin D, when there is hypocalcemia, you can see multiple organs are involved. VTH is stimulated 125 in an attempt to increase the levels. And you have the receptors which are present in different parts in the gut, in the bone, and which try to increase the absorption of calcium, as well as try to form a form of compensatory mechanism. Now, when you have the hypophosphatemic rickets, there is a very important role played by FGF23, which normally is a phosphaturic hormone, and in the normal state is actually kept quiescent. And in this, when there is either a deficiency or there's a mutation in these, the hormones which are the genes which are regulating FGF23, there is an increased action of FGF23, and which then affects the NAPI2 receptors, which actually normally promote the absorption of phosphate. This gets inhibited, these receptors get inhibited, and they actually undergo degranulation and degradation. So it inhibits the action of phosphate reabsorption. Instead, there is phosphate loss in the urine. So this FGF23, it is present in the skeleton, in the bones, and it is present widely in the teeth. Now, FGF23 is stimulated by the actions of, the production is stimulated by the action of the FEX gene and the DMP gene. So that is where the importance lies there. Now, FGF23 has to bind to Klotho in order to exert its action on the FGF1 receptors. And once it is stimulated, this promotes the reduction in the action by degradation of the NAPI2A and the NAPI2C, which are present in the kidney, and that results in excessive loss of phosphate in the urine. So normal action is the reabsorption of phosphate is through the NAPI2A and C. Once FGF23 binds to the Klotho and gets upregulated, there may be increased secretion and resulting in low phosphate levels. It also lowers the 125 hydroxy vitamin D, and therefore results in rickets. So as I've said, the normal action is to keep the FGF23 in check, but when so that it doesn't have this phosphaturic effect. But when this there are high FGF23 levels, it results in hypophosphatemia. And this may be due to the FEX mutation, which is the abnormal cleavage of FGF23, or it is FGF23 gets mutated. Again, it becomes resistant to cleavage, or there are some tumors which increase the production of FGF23. All these, so once, as we said, it inhibits an NAPI2 and increases the excretion of phosphate. It also decreases 1-alpha hydroxylase, and so also there is decreased absorption of phosphate. So FGF23, as you can see, plays a very important role in this. This is a child with phosphopenic rickets. It shows predominantly that they tend to have short lower limbs. So they have a sort of short stature with short lower limbs, with all the other findings of cupping, fraying. And this is a similar finding of a child. And they also are prone to dental abscesses and dental caries, so as shown here. And also they may have bent bones or genu recurvatum that may occur. So alkaline phosphatase again is a very important marker in, and this is the bone-specific alkaline phosphatase. We also know there's an alkaline phosphatase associated with liver disorders. Unfortunately, it's not very, we measure the the whole alkaline phosphatase, and we're not really able to measure the bone-specific alkaline phosphatase. However, it is known, it is increased in, it is bony in origin when it's increased. It is highest in infancy and puberty, and then it troughs a little bit in mid-childhood and post-puberty. A very important sign that it is highly elevated in calcipenic rickets, up to even 2000, whereas maybe only moderately elevated in phosphopenic rickets. And it may be even normal in or reduced in conditions which can mimic rickets like Blount's disease, metaphyseal dysplasia, or even hypophosphatasia, where alkaline phosphatase may be almost normal. I mean, very, very low. Sorry, not normal. It will be very, very low. So these are some of the mimickers of nutritional rickets. You have metaphyseal dysplasia, where you see metaphyseal or epiphyseal fraying, but there's no irregularity of fraying at the ends of the bones. It may also be seen in osteogenesis imperfecta, but here you see multiple long bone fractures, and you can see evidence of healing. Osteosclerosis and hyperostosis may be seen in the hypophosphatemic rickets autosomal type, recessive type, or you may see it in you see areas of radiolucency in hypophosphatasia. So these are some of these X-rays showing can look very similar to rickets, the metaphyseal dysplasia. You can see multiple fractures here in osteogenesis imperfecta and very rarefied bone. Tumoral calcinosis, you can see the calcification, and in hypophosphatasia, the typical radiolucency. And there are different types of hypophosphatasia, and the very early form can also be lethal. So this is a very important chart that actually one should carry in your pocket, because sometimes it's very difficult to remember which is high and which is low in which type of rickets. But just some few key pointers. So alkaline phosphatase is increased in all. Parathyroid hormone is also increased in all except in hypophosphatemic rickets. Again, calcium is low in all except in hypophosphatemic rickets. And phosphorus is low in all except in renal failure. So these are some of the clues that might actually help you to decide which one belongs to what. Now, we do a urine phosphorus definitely when we're trying to look at to diagnose hypophosphatemic rickets, and definitely the wasting is very high in these situations. Bicarbonate may be useful when we are trying to look for rickets due to renal tubular acidosis, but it may require further testing when we're considering that. Another important clue for vitamin D. So as we know that it is low in nutrition and RTA, but in the type 1 rickets, dependent rickets, it is 25 hydroxy is actually high in both of these rather than low. But it is the 125 hydroxy which is low in type 1 VDDR1, and it is both are high in type 2. So unfortunately, 125 is not so freely available. But if we are suspecting VDDR dependent rickets, then it is important to try to look for this test. It is done in a few labs. In hypophosphatemic rickets, you may actually have a normal 25 hydroxy, but a low 125. And in renal failure, we know that both are low. So this is a very useful guide. And when we are trying to evaluate, it is good to have it with us. Now, the features, all the clinical features of rickets, I don't need to go through all of these. Most of them we know. It's just important to know that vitamin D rickets can definitely involve and have dental decay, hypoplastic enamel, delayed dentition, and even abscesses. And therefore, good to look into the oral cavity to look for signs of suggestion of non-deficiency, vitamin D deficiency rickets. Now, this is a publication that came from very recently from the group at JIPMA, and they actually brought out the clinical profile and the genetic profile of children with rickets. They show some easily different symptoms. Important to just note that when you see polyuria and polydipsia, likely to be distal RTA and Fanconi syndrome. So amongst the different types of rickets, they actually found the most commonest were due to distal RTA and the various different types under that. The second most common was Fanconi syndrome, amongst which cystinosis was the commonest. Hypophosphatemic rickets was also there. It was mostly the X-linked hypophosphatemic rickets. The vitamin D dependent rickets were there only in a very small proportion. And there were even a couple of Barters who had rickets. Now, just a couple of words about hypophosphatemic rickets. It generally manifests quite early in infancy and childhood with skeletal deformities and growth plate abnormalities. But it most commonly, almost 80% are due to the X-linked hypophosphatemic rickets and cause lifelong problems. So a good clinical evaluation is required, and the treatment involves vitamin D and phosphates. But there's also a newly available drug called burosumab, which is, sorry for the spelling, which is specifically only for the X-linked hypophosphatemic rickets and not for the other forms, and therefore the role of genetics come into the picture, as it is not useful in the other types. So it is characterized, it looks quite similar to nutritional rickets at times, and there is a poor growth, deformities of the weight-bearing joints, all the features of rickets. They also may have hypotonia, delayed motor development, myopathy. They may present with a waddling gait and in-toeing. But what is quite important to note is a disproportionate short lower limbs, typically after 1 year. Look for dental abscesses, and often there's a family history, so one should look for that. So it's important to know, now we'll come to the diagnosis, and it's important to know that if you make a wrong diagnosis or a delayed diagnosis, you may actually result in an inappropriate treatment of rickets and then end up with a poor outcome. So it starts with a good medical history, a good examination. Then we'll come now to the, which we've already talked about to some extent. We'll come to the biochemical tests. The radiography may not be very different between the different forms of rickets, but there is definitely now a role for genetic tests, especially when there's in those with no family history, but a genetic form is suspected. So we start with the workup, the biochemical workup, which is important to check all the standard tests of vitamin D, which is calcium, phosphate, alkaline phosphatase, and urea creatinine, all the electrolytes. If you can do a bone-specific alkaline phosphatase, it is good, but otherwise we just will do the standard tests, and you can look at the liver enzymes. The parathyroid hormone, the 25-hydroxy, is extremely important, and in some situations, if needed, we can go for the 125. And FGF23 is not freely available, but it is available in some labs. Again, if you want to further categorize the type of rickets. Urine examination is useful always. It can give you a lot of information about the pH and the excretion of glucose and protein. Then in certain situations, you may do the urinary electrolytes, sodium, potassium, again, when you're thinking of tubular disorders and wasting. But we often would calculate phosphate wasting if you're thinking of hypophosphatemic rickets. It's important to look at the GFR, the calcium creatinine ratio, the phosphate creatinine ratio, the fractional absorption of phosphate, and if possible, also to do the TMP GFR. So this is the formula we use. We look at the phosphate excretion by the, which is by the denominator of the creatinine, because the creatinine is the standard. And that is the amount of excretion it tells you. So what is the reabsorption? The reabsorption is 1 minus the excretion. Now it is important to calculate the TMP GFR, because sometimes excretion is so high that the kidney is able to absorb all the phosphorus that is produced in the body, and so it can give you a falsely normal TRP. So it is important to calculate the TMP GFR, which actually also tells us that there is a decreased threshold of phosphate wasting, and below which all the phosphate is being absorbed and the rest is being excreted. So you will notice that the TMP GFR has been reduced in these children with this thing. With hypophosphatemic rickets. So this is a normogram which you're mostly familiar with, where you have the plasma concentration of phosphate against the TRP, and that will give you the TMP GFR, and it is usually decreased whenever there's excessive phosphate excretion. The X-rays, as you can see in different forms of rickets, we aren't really able to, we're seeing the similar findings. So often we are not able to distinguish between the different forms of rickets. Genetic testing, as I already said, consider whenever available. There's a family history, you can go for targeted sequencing, and there are multi-gene hypophosphatemia panels which are also available. So these are some of the different mutations that are associated with the hypophosphatemic and the vitamin D rickets. I will only quickly run through them. The rest is what has already been explained. But you have the autosomal dominant, which is associated with the FGF23. You have the X-linked hypophosphatemia, also the FEX mutation. The recessive type 1 is due to DMP. The type 2 is due to ENPP. And you have the hypophosphatemic rickets with hypercalciuria, which is a SL3 mutation. And phosphatemic rickets can also occur due to deficiency of phosphates. And the FEX gene, which is associated with increased expression of FGF23 and impaired cleavage, whereas the dominant may be due to resistance to degradation, and the recessive types due to increased FGF23 expression. So this is, I'm just showing you this to understand that there is a strong association with FGF23. The vitamin D type 1A is due to the CYP271 mutation, and the CYP type 1B is due to the CYP2R1 mutation. The type 3 is due to the CYP3A4 mutation, and so on. And basically, when you have nutritional rickets, it is purely due to vitamin D deficiency. The type 1A is due to impaired synthesis of 125. The 1B is due to impaired synthesis of 25-hydroxyvitamin D, whereas the 2A and 2B are due to impaired signaling of the VDR receptors. And you have the type 3, where it is due to inactivation of the 125 hydroxyvitamin D. And you have the hypophosphatasia, which occurs due to a different mutation. Similarly, you have the FGF23 increased expression in the bone, which results in all the non-renal type of rickets. And you have the hereditary hypophosphatemic rickets, which actually, with hypercalciuria, actually involve the NAPI2 receptors. The recessive type rickets, due to which we know as the dense disease, also due to loss of function as the CLCN5. And another one, which is the hypophosphatemia with nephrocalcinosis due to lack of function of the NAPI2 in the proximal tubule. Cystinosis is due to accumulation of cysteine in the proximal tubule and is not related to that. And the iatrogenic causes may be due to drug toxicity. Now, I'll just come to a few algorithms before we near the end. So there are different ways of approaching this. So it could be rickets may be due to either radiological evidence of healing, which is we call nutritional rickets. If there's no evidence of healing, then the next thing you could do is the creatinine. And if it is high, it is azotemic rickets. If it is normal, then you do an ABG and phosphate. If there's acidosis, then it's an RTA. If there's no acidosis, with a high PTH, it's a VDDR type 1 or 2. And if it's a normal PTH, then it could be hypophosphatemic rickets. So this is one very simple algorithm. There's another one where you can start with the phosphate. If it is low, then you measure the PTH. Again, if it is normal or low, then you check the levels of phosphate. If the levels of urinary phosphate are high, if you can measure FGF23, you can do it. But if it is, so as we mentioned, if the FGF23 is high, then it is due to some mutation like the hypophosphatemic rickets or acquired form of rickets due to FGF23. If it is low, then it could be rickets with hypercalciuria or Fanconi's. And if your levels of phosphate are low, then it could be just from insufficient intake or decreased absorption from the gut or some redistribution. The third method is if you check the TMP-GFR and do the phosphate creatinine ratio. Now, if it is normal, it means it has adapted. The body is actually compensating and trying to adapt, and you have a normal urine phosphorus in the setting of hypophosphatemia. It could be just nutritional. Either it is due to deficiency of intake or some other cause. Whereas if there is wasting, then again you do the PTH. If it is increased, then again it could be the dependent rickets. If it is normal, then you try to do the FGF23. And similarly, if it is low or if it is high, you can follow a similar pattern. Now, just some important clues about the differences between calcipenic rickets and phosphopenic rickets, which is quite useful to know. So you may have muscle weakness in phosphopenic rickets. Bony pain is more common in calcipenic rickets. All extremities are involved in calcipenic rickets, but in phosphopenic rickets, it may be predominantly lower limbs. Tetany may be present and along with enamel hypoplasia and calcipenic rickets and not present in phosphopenic rickets. Dental abscesses are present in phosphopenic rickets. Serum phosphorus will be low in calcipenic rickets and also low in phosphopenic rickets. Alkaline phosphatase will be markedly elevated in calcipenic rickets, not so much in phosphopenic rickets. PTH, again, a very important point, is elevated in calcipenic, but normal or very minimally elevated in phosphopenic rickets. And osteopenia is present more in calcipenic rickets. And the dental involvement is present in a lot of these conditions. So calcipenic rickets, you have a hypoplastic enamel, dental caries, and delayed dentition. A very important one is the one that we recently reported by the renal group in India is the amelogenesis imperfecta. And surprisingly, we found quite a few cases where they have delayed dentition and typical clinical signs. And this is related to the WDR72 mutation. So something also and associated with distal RTA. So this is something that we should also look for in children with distal RTA. Now I'll come back to the cases and quickly run through them and see if we can remember what was associated with what. So the first child was a normal child, just anxious parents, everything well grown, no symptoms, normal calcium, phosphate, alkaline phosphatase. So this is likely to be just physiological bowing and needs to be reassured. The second child had a history very frankly suggestive of malnutrition or because of chronic diarrhea, poor dietary intake, and he had all signs of malnutrition, wide open AF with all this. Here the calcium was low, the phosphate was also slightly on the lower side, alkaline phosphatase high, the vitamin D was low, and the PTH, there was a compensatory increase. So most likely this is nutritional rickets, and we have to give the treatment and see the response. Then the third child is a known case of PU valve. So there was a clue that this could be renal, definitely in origin, though there was a little delay on the parents to seek the doctor's opinion. So he had stunting as well, but he also had a slightly high BP. So that's an important point. And he was also stunted. So he had anemia. The hemoglobin was low. The bicarb was low, but the chloride was normal. Calcium low, phosphate was high, another clue. Urea creat was high. Vitamin D was low. PTH due to secondary hypoparathyroidism, and alkaline phosphatase was high. So this is likely to be due to CKD. Now, this fourth child had, again, bowing of legs, treated with vitamin D, no improvement. This had dental caries, all signs of rickets, but had a disproportionate short stature, poor dentition. So when you look at these tests, the electrolytes, urea create were normal, calcium was normal, phosphate was low, and alkaline phosphatase was high. Again, vitamin D was low and phosphate was low. So here, of course, you'd need to do further studies to look at the phosphate excretion and the TMP-GFR. But this child most likely had hypophosphatemic rickets. Now, this child, the 5-year-old child who was developmentally normal, growing well, was even treated with vitamin D, but there was no response. But the child definitely had some signs of alopecia. The child also had tetany. And when we did the tests here, we saw the calcium was also low, the phosphate on the lower side. Alkaline phosphate is extremely high. But what do you do when the vitamin D3 is also normal? But it looks like it's some form of rickets. PTH is also elevated. So there is some response, something that is wrong here. So here, this is where a 125 dihydroxy vitamin D needs to be checked. And based on this, especially if it is low or it is high, we may come to a conclusion. In this particular child, the level was on the higher side, and the signs that seem to fit in because of the presence of alopecia, most likely this was a type 2 vitamin D dependent rickets. Then coming to the last case, where this child definitely had a history of polyuria, polydipsia, poor growth, probably some dehydration because of this constant polyuria. Also had a liver palpable. So that was an important clue. And when we did the electrolytes, we could calculate the anion gap when it came to 12. Creatinine urea is normal. The urine pH is 5. And you also see that low calcium phosphate, high alkaline phosphatase, slightly low vitamin D. So there is some vitamin D deficiency definitely with a PTH response. But the AFP was done because of the hepatomegaly, the alpha fetoprotein, which was markedly elevated. And this, so it obviously something which involved the liver. There are others like Fanconi-Bickel syndrome and glycogen storage type 1. But here they seemed, because of this AFP elevated, most likely hereditary tyrosinemia. So very briefly about the treatment goals, it involves a multidisciplinary team, not only to treat the rickets, but you need to improve the growth, decrease the deformities for which you need the orthopedic intervention. You need to decrease the symptoms of bone pain and also improve the muscle strength and ambulation. So I'm not going into the details of treatment. This is for the vitamin D deficiency where the standard doses are given and there are different types. But just a note about the vitamin D resistant rickets, especially the type 2, where you need extremely high doses of vitamin D and alpha calcidiol. As you can compare with type 1, the doses are extremely high. They can have severe hypocalcemia and they require very, very high doses of calcium as well, to the extent that sometimes they may actually need calcium gluconate infusions. So I'd like to end here saying that the diagnosis of rickets is based on typical clinical symptoms and radiological symptoms. And we need to look carefully at these clinical symptoms to look for what is different. Nutritional rickets due to vitamin D deficiency or calcium deficiency is the commonest. The hereditary causes of rickets due to mutations in the genes involve vitamin D metabolism or action. They involve renal phosphate absorption or synthesis and degradation of the phosphaturic hormone, FGF23. Genetic confirmation is helpful in planning therapy. Understanding the pathophysiology of the different types of rickets really helps in the diagnosis, and therefore this is something that we need to keep in mind. So I would just suggest these are very good articles which came out in pediatric nephrology and explain the whole pathophysiology extremely well. And I would suggest that these articles can be read for further understanding of the topic. Thank you.
Thank you very much, ma'am.
Thank you, ma'am, for a wonderful presentation. You made it really easy. I request our experts, Dr. Ruxana and Dr. Praveen Kumar, to say a few words. Then we'll open the house for the discussion.
Okay.
Thank you, Indira. Thank you, Indira. Very, very good presentation. You've covered so much in 30 minutes. That's remarkable. And you've given us so many really good algorithms and treatment guidelines. That's absolutely excellent. Very well done. Vitamin D is becoming such an interesting thing the more you read about it, and it comes in so many different aspects of healthcare now, including immune, as you were implying, also that child with multiple infections. So perhaps an immune a role in immune mediation, a role in an anti-inflammatory effect, and even probably an anti-proteinuric effect as well. So from a renal point of view, from a kidney doctor's point of view, it's got so many different aspects. Of course, when presented with a child with rickets, you've given us very good algorithms. Common things being common, it's most likely nutritional, but then of course you've got to think further based on a detailed history and management plan. Vitamin D resistance is also seen in kidney failure. So perhaps we need to think further in children with kidney diseases, even early stage kidney diseases, about about vitamin D and keeping levels at a somewhat higher range than in healthy children, in non-renal failure children. One other aspect probably to consider and for discussion is that we may be seeing an era of vitamin D toxicity as well at some stage, because as more and more people become aware of vitamin D, the health, these so-called healthy foods and the supplementation of foods, and people take excessive doses of vitamin D thinking if a little bit is good, more is even better, and end up with nephrocalcinosis and toxicity. So perhaps a few words on that as well. Thank you again. Really great talk. I'll hand over to Dr. Kumar now. Thank you.
Yeah, so thank you, Dr. Indira Agarwal, ma'am, for giving us broad spectrum, so many. So as ma'am has highlighted, this is a multi-system involvement you can have in vitamin D. So there are problems with endocrinal, we have renal causes, and one has to aware. But at the same time, just now also we will have nutritional more common, and one has to see, and ma'am has given a very beautiful algorithm about when there is no healing, then we have to start thinking of the other causes and other system involvement. Uh, and genetic workup has definitely given us more confidence about the diagnosis, and more cases of vitamin D resistant now are being diagnosed, and we have a definitive diagnosis. So only one comment regarding the case 2. I think in particularly in our area, we will definitely rule out celiac disease in this case because of chronic diarrhea, and particularly because this area we have cases like this.
Yes.
So thank you very much. And I think if we have any other comments, we can take. I don't see any question at this point of time. Uh, but if there is any other comment or otherwise, it's over to organizers. Thank you. Thank you.
Thank you, Dr. Praveen.
Thank you, sir.
We have
Yes.
welcomed Dr. Dinesh, Secretary, IP Delhi, and Dr. Ravinder Kumar, Secretary Elect cum Treasurer, IP Delhi.
Thank you, sir, and very good morning to all of you. And it was a wonderful session by Dr. Indira Agarwal, ma'am, on vitamin D and rickets. I hope many queries are solved. And a wonderful comment by Dr. Praveen Kumar, the chairperson for the session. Dr. Ruksha Saraf is also there. Welcome you, ma'am. And this is the third session in the continuation of Master E classes Pediatric Nephrology. And we are going good. Thanks to Dr. Neha also. Now, for vote of thanks, I would like to invite our Treasurer Secretary like Dr. Ravinder sir to say vote of thanks. Before that, Dr. Ajay want to say something?
Yeah.
Yes.
I wanted to ask Dr. Indra,
Yes.
the IP guideline, they say regular supplementation of children up to 1 year of age with vitamin D. So after that, even after 1 year of age, their sun exposure remains quite low. In summers, they do not go out. In winters, they are so clothed. that they do not get in much of a sun exposure. So what do you suggest for such children?
So one can have, I mean, it depends on the protocols that one follows, but we used to actually often give this supplementation on a yearly basis. So there's no harm. As we know, just even exposure to sunlight is not enough because we have darker skin and absorption is poor. And or in extreme heat, sometimes we cover ourselves or we use sunscreen. And so the risk is always there for deficiency. There's no harm in actually making a protocol for giving yearly vitamin D. That would depend on the deficiency is definitely there when we actually check it in the. We've seen even doctors have deficiency. School-going children have. We are all remaining indoors. Children playing out in the sun also get deficiency. So the risk is high, I think, as a Southeast Asian population is known to be deficient.
Ma'am, nowadays almost 80-90% people are vitamin D deficient.
Yeah, that's true.
So,
And how
Dr.
good is
Ajay,
yes,
may I come in? Yeah.
yes.
So I think when we worked on consensus guideline, we try to look for, but at this point of time, we do not have definite evidence for no advocating routine supplementation beyond 1 year. That is the message. So unless we have definite evidence, it will be difficult to recommend for everyone. Thank you.
Yes.
And how good is the milk source of vitamin D?
Well, we don't, I think, I don't know, Dr. Rukhsana can mention, I think there it is fortified by vitamin D, isn't it? I mean, in our country, the source of milk itself is from varied sources.
Yeah.
Some have it, buy directly from the vendors, the milk goalas. Whereas you do get these packaged milk, but they are not fortified. So I don't think we can think that it is adequate as a source.
But nowadays,
In the
all
in,
packet milk, or mother dairy, Amul, they are all vitamin A, vitamin D fortified.
They are okay.
Yes.
The packaged milk,
In
Yeah.
package, in package.
not the home delivered like.
Yes, not the home delivered.
Just a word of caution for all my pediatric friends. I think hypervitaminosis D we are encountering it a few.
Yes, yes.
Yeah.
And
because
mostly
they're
they
all
have neck pains, they go to the pediatrician,
ready.
6 lakh units injectables, one after the other, 3-4 times, and then they come with very high levels of vitamin D. And I've seen a couple of children with nephrocalcinosis because of hypervitaminosis D. So I think a word of caution that we are giving vitamin D, but excess also is to be looked at.
Yes.
Thank you, sir. We welcome Dr. Suprita. He is again faculty for our eNephro module, and Dr. Lalit Mendirata, past president of IP Delhi. Dr. Suprita, would you like to say something?
Thank you. Very interesting session. I agree with Dr. Vasudev that vitamin D deficiency is probably overdiagnosed with children who have any complaint, just pain in legs, some kind of, even mother will say fever on and off, anything. And people send vitamin D, it may come borderline low, and the children keep getting vitamin D. Whereas the children who really have refractory rickets or bone deformities or evidence of tubular disorders, as has already been discussed, they need early referral and maybe detailed evaluation.
Thank you. Over to Dr. Dinesh.
Thank you, sir. Thank you, sir. Wonderful comments and wonderful inputs. Now I would request Dr. Ravinder, sir, to say a vote of thanks. Dr. Ravinder is here?
Yes, yes.
Okay, thank you, Dr. Dinesh, and good
Yes,
morning
yes.
all.
And he himself is a endocrine expert also, and he can also give the comments on vitamin D. Thank you.
Thank you, Dinesh. I'm just listening to and learning to all of you. So first of all, thank you, Dr. Dinesh, Dr. Ajay, for taking this initiative. Thank you, Neha Bandari. I think now she has become a torchbearer of pediatric nephrology after Vasudev sir. I think Vasudev sir has passed on his legacy very well because Neha is a true keen to teach pediatric nephrology. She has conducting for last couple of years clinics, let's say also very informative. So thank you, Dr. Indira, Dr. Praveen Kumar, Rukhsana, Dr. Lalit sir. And just two things because this topic is very close to my heart. First of all, yes, sir, hypervitaminosis now has become a problem. I don't know when will we be away with this 6 lakhs intramuscular vitamin D. I think it should be the messages should be very clear and very loud that we should go away with this because 6 lakhs dose is nowhere recommended. Number one, number two, it should not be injection. Otherwise, so many injections patients are receiving. Number two, as far as sir, after Ajay sir, you have very pointed. I mean, it's a very good question. After 1 year of age, vitamin D requirement increases to 600 IU, and what we are having from natural sources is very, very low. Milk is a very poor source of vitamin D. Hardly there is max, you can say 20 IU in 1 liter. As far as fortification is concerned, I think not all these dairy milk are being fortified. I think it's just Mother Dairy who has fortified. That too only, I think, this stone milk. They have added 200 IU in 1 liter. So that's only as far as I know. Apart from other milk and other products, even of Mother Dairy, they are not fortified. So yes, how to fulfill because Indian is a a vegan. We most of the time is having a vegetable diet. We don't go for fish and all these egg yolk and all this. And as far as SEM exposure is concerned, so in most of the metro city, see the scenario at Delhi. Out of 9 months in 12 months, we are at indoor in the AC because even sun exposure, it has to be from somewhere 11 a.m. to 4 p.m. That too, at least your 30% of the body surface area should be exposed, which is becoming difficult. So these are the difficulties which should be addressed. Although Dr. Triveen has rightly said why the IIP has forming guidelines to supplement after 1 year, they still say it has to be from natural sources. So obviously it has to be from natural sources. But how is becoming a problem. So anyway, it's a nice discussion. We should, apart from deficiency, we should think of this toxicity also. The more than 100, if you are having 100 nanogram, it is toxic. And if someone is having more than 50, then think of he must have received couple of doses. Otherwise, that high level of vitamin D is unlikely. So thank you all. I think Dr. Lalit sir wants to say something. Yes.
Good morning, everyone. I just enjoyed every part of the session. My basic question is that what is the role of calcium supplementation along with the treatment of rickets, and how long we continue it? We monitor the levels of vitamin D and then discontinue, and how long? And when it is absolutely essential?
So we always give calcium along with vitamin D because it's the substrate that's needed for the bones, for the healing of the bones. So we tend to give it for at least another 3 to 6 months, depending on what the underlying cause is. So if there's an ongoing loss of, there are nutritional rickets, you might actually be able to build up the levels. But in some of these causes, which are renal rickets or where you continuing the treatment with vitamin D, you have renal failure rickets, then in those situations, you continue giving calcium. But for nutritional rickets, about 3 to 6 months till you're sure there is healing, we generally follow it up with that X-ray. If we are doing X-rays to look for the calcification. And so definitely, but calcium needs to be given with vitamin D. Otherwise,
and we should always one last thing. We should do a routine test in all suspected rickets.
Yes,
we should
it
always
is advisable. Yes, because it's incomplete without that. It gives you the additional information as to what the cause is.
Thank you. Thank you.
Just one word, Dr. Lalit, about PTH. When you are sending PTH, it's a very heat level actually hormone. So it should be ice packed. Otherwise, the moment it is going to the lab, it may degrade it. Or better that it should be done at the lab site itself. Well, this we have to be very careful while advising.
Thank you very much, sir. I think it is very important. Dr. Ravinder sir has made a very, very valid point about PTH, and especially timing is also very important, that it should be done between 8 to 10 a.m. in the morning. And I would request all the delegates to please go through IAP has given very beautiful guidelines on vitamin D in 2021. Actually, a lot of things we all should go through those guidelines. I have shared it in the delegate group already. So, Ravinder sir, if everybody's okay, Ajay sir, we can.
Yes, sir.
Yeah.
Thank you so much.
Thank you.
The Mother Dairy, I've just looked at the Mother Dairy milk. This is fortified with D2, a very, very small quantity, which is not adequate. So I looked at the contents and maybe.
This is told or which one? This is told, Mother Dairy?
Yeah, this is the one.
How many units?
Units, micrograms, ZIAOS, micrograms, but very small quantity. So I think Deficient.
Yeah, very low. I mean, it's only told there. Other, even they have not given in full fat or double tone. This is the problem, sir. And D2 again, it's a very, not that appropriate as B3.
Dr. Ravindra, please conclude the session.
Thank you, sir. Thank you all. Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you, ma'am.
Goodbye.
Thank you for joining in. Thank you, Dr. Indra, ma'am.
Thank you. Bye-bye. Bye.
Thank you, everyone. Thank
everyone.
you. Good day.
Thank you, everyone.
Happy Sunday.
Bye. Bye. Same to you, sir.